Welcome to the Office Hours Quality Payment Program conference call. My name is Richard and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Mona Matthews. You may begin.
Thank you, Richard. Hello, everyone. This is Mona Matthews. I'm a project specialist with Lake Superior Quality Innovation Network, and we serve Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome all of you to this session of the QPP office hours. Today's call will be operator assisted. By default, right now you're all on mute to avoid any background noise. Since this is an open office hours, there will be an opportunity to ask questions over the phone, at which time Richard will provide instructions. We will also be closely monitoring the chat box and encourage you to post questions or comments throughout. Also, please note that the information provided during this session is based on the latest information made available by the Centers for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review the specific statutes and regulations that may apply to you for interpretation and update. At the end of the office hours, you'll have an opportunity to complete a brief evaluation. We encourage you to provide us some feedback about this event and suggestions for future educational opportunities. We'd also like to remind those of you that received direct technical assistance related to QPP to please take the time to complete evaluations sent at the conclusion of each technical assistance encounter. Your feedback is very valuable. So I'd also like to mention that we are taking some notes during these office hours, and we can typically address a broad range of questions which are based on the equally broad range of QPP and MIPS knowledge level of our call participants. Some questions we will be able to answer very quickly. Others may require some additional time to research due to the complexity of the question, while others may be specific scenarios to your organization. We have implemented a new process to capture all of the Q&A presented during these calls. Questions that our team deems broadly applicable to all the audience will be emailed to the participants within the next couple weeks. Those that are very scenario specific, our team will address directly with the attendee via email or phone. Finally, questions that require more research or those that appear frequently will be addressed at our next office hours. I would also mention that today the caption that usually automatically loads is not automatically loading, so you will need to follow a link that's in chat if you find that useful. Then during today's office hours, I'm going to spend a really short amount of time reviewing some of the basic information about the Quality Payment Program. Due to the timing of this webinar, though, I need to mention that we had due dates that were associated that made it that we needed to get these slides out prior to the release of the new 2019 rule, so I don't have any slides related to the proposed rule. The subject matter experts have reviewed many of the documents related to the proposed rule, and questions about that proposed rule are welcome today, so you don't have to exclude your questions. It's really hard to believe, but we really have 3 years of the QPP in play today. Our subject matter experts will do their best to answer questions regarding the 2017 performance report, the 2018 reporting period, and the 2019 proposed rules. My slides focus on the information about the reporting and list some new resources. And I'm going to just advance the slides, and if I can get. So the disclaimer is here that I already read. So just to start with a really short overview of the Quality Payment Program today to set the stage, most of you on the line are probably aware that there are two ways to participate in the Quality Payment Program, MIPS and Advanced APMs. The eligible clinicians for 2017 and 2018 remain the same. They're listed here: physicians, nurse practitioners, physician assistants, clinical nurse specialists, and certified registered nurse anesthetists. On this slide, we talk about the low volume threshold, and as most of you on the line are probably aware, there was some slight changes from 2017 to 2018. So during this performance year of 2018, the low volume threshold was billing greater than $90,000 to Medicare Part B and providing care to greater than 200 beneficiaries. And you do have to meet both of these criteria in order to be eligible. And there we go. This slide, I have listed a variety of new resources available on the Quality Payment Program that you may find useful, and there are links to these resources. And I'm going to review a little bit of information from each of these today. So we'll talk a little bit about targeted review and also the feedback fact sheet and the payment adjustments. And the next slide, please. I don't know why my slides are not advancing. Okay. So we'll start with the performance feedback. Just to start and set the stage for the performance feedback, and most of you are probably aware that the feedback reports came out just before the first of this month. I think it was either the 29th or 30th of June. So who's going to have performance feedback reports? Individual clinicians, including those that voluntarily submitted, should have feedback reports. The groups that reported will also. MIPS APM entities, so those that reported through a MIPS APM will have a feedback report. Clinicians who practice in multiple groups will have performance feedback for each of their groups, so each TIN-NPI combo under that. Partially qualifying APM participants, those that we term as those partial QPs in an APM, will only receive MIPS feedback if they elected to participate in MIPS. And just as a note here, qualifying APM participants, so those who are listed as QPs within an advanced APM, will not receive MIPS feedback reports. The information in the MIPS performance feedback report, you're going to find the final MIPS performance feedback will reflect any special scoring. So those of you who looked in the interim right after you reported before the reports were final, often they did not reflect any special scoring, but your final reports should reflect any of the special scoring circumstances and all the MIPS data submitted or calculated for an individual clinician, group, or APM entity. You will receive a 2017 final score, and that should be listed on your performance feedback report, and 2019 payment adjustment, which is applied to MIPS-eligible clinicians. And just as a reminder, though, the payment adjustment will not be applied to voluntary submitters. And then under each of the activities and measures, you will be receiving a score on your report. So just as a little example of what the report looks like, and I know many of you have probably already looked at your report, but this is the first page. So on the first page of the report, you will receive the final score, which is in that box or the circle in the middle, with 62.9 in my example. And then under there, over to the right of that, it says in the quality this particular group received, or individual, received 35.4 out of 60, the advancing care 20 out of 25, and the improvement activity 7.5 out of 15, and that comes up with a final score of 62.9. The payment adjustment is listed over on the right, and it also gives you the date in which that payment adjustment will be seen for this entity. Each category will also give you a little breakdown on information. And in this example, this is the quality performance category, and it gives the reporting period in which you submitted data, and it gives the highest score submission method for this entity. It was the registry. And the reported measures, they reported 9 measures with 1 high priority, and their score was 35.4 out of 60 available points. So the cost category will also be listed, and this is measure level scores only, and it's only for information. As most of you will recall, the cost category was weighted at 0 for 2017 performance year. Measure-specific details, such as the number of eligible cases or episodes, will also be included in the average cost per episode. And you will have access to measure-specific specifications in your report. So you might, if you haven't already done this, to access your MIPS performance feedback, you will need to log in to the qpp.cms.gov with the same Enterprise Identity Management or EIDM credentials you used to submit and view data during the submission period. Now, if you do not have an EIDM account, we really do encourage you to start that process as soon as possible and get that set up. CMS is strongly encouraging clinicians and practice representatives to obtain necessary EIDM credentials no later than July 31st. If you need assistance with this, you can contact one of us, or you can also submit a ticket through the Quality Payment Program, and we can help you with that. We also at Lake Superior have developed a quick start guide for setting up those EIDM accounts, and there is a link to that resource on this slide for your reference. Now, with the release of the performance report, CMS has also developed a targeted review process. And during this, in the next couple slides, I'll talk a little bit about the targeted review and include when to submit one and what things that you would not submit a targeted review on. So just kind of setting the stage and understanding what a targeted review is. It is a process where MIPS-eligible clinicians can request that CMS review the calculations of their 2019 MIPS payment adjustment. Clinicians are encouraged to request a targeted review at the same level, if you either individual or group, as the data was submitted to MIPS. So possible reasons why you might submit a targeted review: calculations or data quality issues, errors made such as eligibility being wrongly assigned to the MIPS eligible clinician or group, or eligible clinicians did not receive automatic reweighting, or if you have an erroneous exclusion from an APM participation list. So those are some of the reasons why you might want to submit a targeted review. There are some things that are beyond the scope of a targeted review. So they're asking us not to submit targeted review if you are questioning the methodology used to determine the amount of the MIPS adjustment factor. establishment of the performance standards in the performance period, identification of measures and activities, information that is made public on Physician Compare, and the methodology to calculate that performance score. So if you are requesting a targeted review and you feel there's an error in your MIPS final performance feedback, you'll want to submit your targeted review as soon as possible, immediately if possible. The deadline for submission, and I know it says September 30th, and I believe this has changed now to October 1st. So there might be a change in date since this slide was made. But it is really strongly encouraged to submit a review as soon as possible to ensure that the payment adjustments are applied correctly as of January 1st, 2019. And there is a user guide, and that was listed on a previous slide, a link to that. You'll want to review that user guide for more specific information. And targeted reviews are filed by logging into the QPP portal. Therefore, you will need that Enterprise Identity Management account or EIDM account credentials to do that. Another good reason why you want to get that done as soon as possible. So those are the things I wanted to cover today, and my contact information is listed on this slide. And at this point, we will open it up to questions from the group. Richard, can you give people instructions on how to ask a question?
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And we're standing by for questions. And once again, that's star, then 1.
You can also submit your questions through the chat if you have a question. And again, it can be on any of the 3 years of the quality payment program that we currently have in play right now. And while people are thinking about a question that they might have, I know for me, I've had some people who have called in because their reports don't look the way they should. And I know that if you logged in right after they became available, there were some times that the reports weren't entirely finished at that time. So I'd encourage you to look at the reports again. Like if you looked on the 29th of June and that was the last time you looked at it, there may be some things that have changed. Keisha or Reed, are you seeing anything in chat?
This is Reed, and I am not seeing any questions to this point.
Okay.
Mona, this is Candy. I just wanted to, sorry, I joined a little bit late.
Yeah.
We did have a question earlier this week from someone who was questioning why all of their TINs, she had 4 of her TINs in her health system that she did not receive any readmission data on. And what we surmised after she did some double checking was that she didn't meet the 200 readmissions threshold for those 4 TINs did not meet that. So therefore, if you don't meet that 200 readmission threshold, that won't show up on your cost report.
Thank you, Candy.
This is Reed again. Excuse me. One of the things that we could talk about while we're waiting for questions is why did I get the score that I got? And that seems to be the most popular question as of late.
Thank
and
you.
it has a lot to do with the formula that CMS uses to calculate that overall percentage adjustment. And they don't have anything in the system currently where you can click on and see a breakout of how is that score actually calculated in detail. Well, we know the program is budget neutral, and found out through some anecdotal evidence and some other things that about 10% of those participating in the program ended up with a negative adjustment. And being budget neutral means that the 90% positive performers were paid out of that small pool. So how did CMS determine that? Well, they used what's called a scaling factor, and this was not highly advertised. Oftentimes, if you attended CMS webinars, they talk more about up to a negative 4% or positive or negative 4% adjustment, and then kind of a footnote of times a scaling factor. Well, the scaling factor turned out to be close to 0.5%, or 0.5, just a multiplier. So if you performed at the top and got 100 points and were expecting a 4% positive payment adjustment, it actually turned out to be closer to 2%. I believe it was 2.02%. And then other people were asking, well, what about the exceptional performance bonus of $500 million for those that performed at 70 points or up to 100 points? Well, that was also factored in. So when you see your score logging in with your EIDM credentials, you'll see that percentage number, and we had a slide that Mona shared with us that had that green number. And basically that reflects both your overall score and the exceptional bonus if you performed between 70 and 100 points. So it's all rolled into one. And we had a few people ask, how can I tell what I got for that exceptional performance? Well, right now you can't. I submitted some requests, and I talked to a level 2 support person at CMS, and they said we're starting to get that more frequently, and we're pushing that on up the line there to see if we can get, maybe some detail behind that, and CMS could demonstrate to us, our participants, with a calculation of what that actually breaks out to be.
Thank you, Reed. So stay tuned on that. And yet, we are getting a lot of questions about the payment adjustment, because I think many people, especially those that scored real well, and we had a lot of clients who scored 100%, were really thinking that they were going to get closer to a 4% payment adjustment. But to Reed's point, it does need to stay budget neutral, so the amount turned out to be just above 2% that they received for their payment adjustment.
And Mona, we're seeing a couple questions actually came through the Q&A, and I think there's one in chat as well. So if folks can direct their questions through chat, it would be helpful rather than Q&A. But one of the participants asked, is the exceptional performance score included in your payment adjustment? And as I explained, yes, it is, but we can't see what that percentage is exactly. There's no breakout currently. And the same person is asking, a measure I submitted that had 100% performance was in the category. Let me reread that. A measure I submitted that had 100% performance was in the category. Measure submitted but does not count. Why would this be? I think maybe they meant the quality category there.
Yeah. I think that's, I'm not sure. There's 3 ECs.
Yeah, thinking about that myself here.
Yeah, I'm not even seeing the question, Reed. So
that is in the Q&A rather than the chat area.
Okay. A measure I submitted that had 100% was in the category. If the person who asked the question would mind coming on the line, that would be really helpful, because this might be a great question, but we're just not understanding it, and it might be beneficial for all of our listeners today.
I could do a little speculation here. So they were saying a particular measure that they submitted on their end, they saw 100% performance. Maybe they even used like our MIPS estimator or had some sort of assistance with the registry or their EMR or something like that. But why would this not count? Well, it could be a measure that was completely topped out. It could be a measure that the particular vendor, EMR vendor, did not certify for. So you did the measure, but they didn't certify through ONC Chapel, Certified Healthcare Product List, and so it just was not able to be scored because of that. But again, speculation. We need a little clarity on the question.
Yeah. So if you can get on the line, we do have another one in chat. It says we participated in the test submission. We had 3 ECs for 2017. My question is, I received a final score which reflects positively on the EC I submitted information on, but one of my other ECs shows up under this report and has a 0 and appears to have a 4% negative payment adjustment. Can you explain why? And this would depend on whether or not you did a group report for these 3 individual eligible, or these eligible clinicians and the rest of your group, or if you submitted data individually. And I'm not quite sure, based on the question, how these data were submitted. Reed or Candy or Tisha, anything to add?
Yeah, I think just for clarity, this person says we participated in the test submission. So I think what's meant there is that the test pace, as it was called, kind of the marketing name for achieving at least 3 points. So basically that was the threshold for performance year 2017. So it sounds like there may have been doing the minimum just to achieve that 3 points, as it was expecting at least a neutral payment adjustment rather than that full negative 4%. But oftentimes these are scenario specific, and we'd have to kind of walk through what submission method did you do, again, individual or group, etc. There's a lot of factors that go into it.
And again, these questions, if you want to log in and ask them, I really think the discussion of your specific scenario would probably be very helpful for everyone on the line today. So don't be shy. This is complicated, and there's a lot of twists and turns.
And again, as a reminder to queue up for a question, that's star then 1.
We have another question here, came through the Q&A section. Is the example you gave of a final score at a glance an actual example? Why would we receive a smaller adjustment when our final score was 96.13? So they're comparing like the 62.9.
Yeah, and I pulled this off of some material that CMS had put out, and I don't think it's an actual score.
Yeah, I think that's...
I thought the same thing. I wondered the same thing when I looked at this today, just prior. I'm like, this is probably not a real report.
Yeah, I think that was just kind of a mock-up to demonstrate what the look and feel would be like, but the values weren't realistic.
Right. Good question, though, and I should have pointed that out.
And we have a question online from Nyla Roy. Please go ahead.
Yes, hi. I'm the one who wrote regarding the test submission.
Yeah.
So,
maybe explain a little bit.
Well, I don't remember specifically. Was there a test option on the site?
That was a little bit of a confusing thing, and I like how Reed just stated it. It was kind of marketed as a test option, but there wasn't anything when you went to report to say, I am just doing a test case this year. You just reported.
Yes.
So there wasn't an option for that.
It came back reported as group and individual on my actual performance feedback.
Okay. Which was an option for people to report both group and individually.
Mm-hmm. Mm-hmm.
And
I'm not sure.
Go ahead.
I guess I'm not sure where it's. I don't have a final score on the other one that it's showing a negative adjustment.
Okay.
The final score is on my intended person.
just on one person, not as at a group.
Correct.
Okay. What state are you in?
Minnesota?
In Minnesota? I don't know. I know in Wisconsin what we've been doing is maybe getting on the line and going through that report with you. What should have happened if you filed group and individually on your clinicians, each clinician should receive the score that was the highest, and then the payment adjustment that's related to the higher of the either individual score or group score. Anything to add, Candy or Reed or Tisha?
Yeah, I think we would. This is Candy. I think that we would like the opportunity to go through your report with you, because I'm sitting here thinking, well, I'm wondering if you need to do a targeted review request, and we would be able to know that better if we were able to see what you're looking at.
Okay, that'd be great.
So, if you,
go ahead. Go ahead.
I was just wondering if we're posting our help desk emails at the end of this, I'm assuming?
Yes, they are at the end.
Okay, so if you just be so kind as to just go ahead and shoot us an email to our help desk, we'll get in touch with you and we'll figure this out.
I will do that. Thank you.
Yeah. Just the email isn't on at the end. I thought there was another slide to this presentation with the email. So in Minnesota, that help desk email is, if you can remind me, Candy, QPP, your help desk, Reed or Candy?
QPP help at stratushealth.org. So QPP help at stratishealth.org, all one word.
Yeah, let's throw it in the chat, should we?
Yeah, maybe that's a good idea. Thank you, Candy. Good. And with the targeted review, I wanted to point out that don't fear having to do one of those, and you fill it out using your EIDM credential. And for me anyway, for the Wisconsin sites that have filed these, they're getting reports or results back within a day or two. I'm not sure what the experience is of Michigan or Minnesota on that, but you are getting a response I'm getting responses quite quickly.
Well, and not only that, that is the only mechanism to challenge the score. So you definitely want, if you're thinking something not right, it's definitely worth your time to go through and do it.
Yeah.
This is Reed. We've got another question here in the Q&A area. Did you indicate the highest adjustment available was 2%? Yes, I did, and it's close to that, not exactly 2%, just slightly over that.
It was like 2.01 or 2.02, wasn't it? It's something, I don't remember it off the top of my head.
Yeah, I think it's close to like 2.02, and then there's some folks that had a little bit of the exceptional bonus in there. It might have been 2.05 or whatever, somewhere close to 2. And I think we had a table, Candy or Lisa, didn't we have a table, kind of a visual showing the 70 points on up to, actually even below that, it was starting at 0 to 3 and then on up to 100 points of examples of what the actual final percentages were for the payment adjustment.
We do. Actually, we had it for a previous meeting this week. But I'm wondering, as a follow-up, Mona, if we couldn't just send that out with the questions that we'll get to everybody?
Yeah, we can. Yeah. Tisha can add that to her. Tisha's taking the notes today. Okay. Do we have anybody else in the queue for questions?
And once again, as a reminder to queue up, that's star then 1 on your touch-tone phone.
And for anybody who wanted some further information about the topic that Candy talked about with the minimum of 200 cases for the readmissions, Lisa has put something in the chat that explains some of that. So you might want to take a peek at that.
Yeah, this is Lisa Gall from Stratus Health, and I had responded to the help desk question that Candy referred to about the cost category. But Candy, and frequently we kind of understand and interpret questions a little differently, and so that's not uncommon in our calls that we kind of clarify each other's interpretation of the rule. But what I did on that particular case on the cost category, the reason they didn't get a cost score is because it's actually taken by two methods, the Medicare spending per beneficiary, and the case minimum for that is 20 eligible cases, and the total per capita cost case minimum is 35 eligible cases. So if you don't meet those two things, you won't get rated, if you're below any one of those thresholds. So that might be what happened in those particular process. And there's also an attribution step. It's a two-step process that takes into account the level of the primary care services are received. And so it's a little complicated, but basically if you don't have that cost score, it's because you didn't meet the thresholds most likely.
Very good. And we do have another question that is in chat. It says in 2017 we used the certified healthcare home as our improvement activity. Can we use this again in 2018? And the short answer is yes. I have not seen anything that prohibits anybody from using the same improvement activities that they used in 2017 for 2018.
This is Lisa again. Can I add on to that?
Sure,
if
absolutely.
you use the certified healthcare home as your improvement activity, you'll get full credit. However, if you don't list an improvement activity and you did one, you could list an improvement activity besides that healthcare home certification and scoring so that you can get a bonus point in the promoting interoperability. You won't get the bonus point unless you put an improvement activity in there and state that, yes, you did use it in your EHR, and that activity was eligible for a bonus in promoting interoperability.
And this is sorry.
Oh, go ahead.
Candy, I was just going to say, when you're looking at improvement activities other than being attesting that you're a certified medical home, you really want to make sure that you look at the activities for 2018 because some of them have changed. There is one particular activity that you can only do every 4 years. So you really want to look at the specifications of your activities to make sure that, you're going to be okay with what you're choosing.
Yeah. Thank you for that clarification.
And we have an add-on question there. Would it have to be a separate improvement activity? And I think what they're talking about is activities that you're doing as part of being a healthcare home. Would you have to do something unique, if I'm understanding that question correctly? And no, it's just the fact that you have to indicate that you're a healthcare home and kind of proactively go in and report on one of those that may be an activity that you're already doing as part of your healthcare home certification. But I think what Lisa was trying to clarify was you have to enter that in order to get the bonus and credit for the promoting interoperability category. Just it's the act of reporting on it, rather than expecting an umbrella healthcare home certification to cover and get the bonus. That wouldn't happen.
Right. Very good. Any other questions? For those of you who have spent any time in the proposed rule for 2019 that came out late last week, or I think it was like a week ago today. The one thing that there's several changes that they're proposing, but as kind of promised in 2018 and 2017, they are adding eligible clinicians to the list of eligible clinicians. And there is a process if you want to submit comments on the proposed rule, you can do that, and there is a process to do that, and we can help point you in the right direction if there's things that you want to do, or it is attached to the proposed rule that I think each of us sent out last week, the links to that.
So Mona, this is Reed. I would add to that the comments are due by September 10th. And so what does that tell us overall? Well, we know that once the comment period closes, that CMS needs about a month or so, sometimes a little bit more, before the final rule comes out. So our expectation is that sometime in November, and typically these things come out around a holiday period. I don't know why that happens. I have some ideas, but I would surmise, if I had to be a guessing person, that sometime close to Thanksgiving or perhaps prior to that, that's when we'll see the final rule. Why does that matter? Because at that point, then we have certainty about what we need to do in 2019 for that measurement period.
Yes, thank you.
Another thing I might add that we kind of need a little lead time to think about is the fact that they are sticking with 2015 certified EHR technology as a requirement. And the reason for that primarily is CMS leadership, Seema Verma, came out and said we're really focusing on interoperability. Well, we can't do interoperability without some technical capability in our EMRs, and application programming interface, which is kind of the handshake to the outer world through the web and other technologies, is embedded in that 2015 certified technology. So if they were to back off that requirement, that puts a little bit of a hole in their approach to promote interoperability, which they are kind of, now that we have that whole category renamed advancing care information into promoting interoperability. So that is what is happening at a very high level. There's a great fact sheet, and I don't know, Mona, if we could, or Tisha, that we could send that out, a link to that as part of our follow-up, just so people can kind of review. And it breaks, the fact sheet is much shorter than the actual final PDF, and it's about 28 pages, but there's a nice table in there, and it talks about the different categories and what's going on and proposed changes, as well as just the highest level concepts that I shared.
Yeah, and we would, probably in our next month's office hours, we'll focus a little bit more on that proposed rule. Like I said, the due date for the slides for today was prior to the proposed rule that came out.
Yeah, we don't have any particular urgency around this proposed rule right now. We're all just kind of digesting it and looking through the detail.
And maybe another ask for any questions that people have or comments that they want to share with the rest of the group that you might find helpful. If there's someone on the line that has filed a targeted review and would like to share that experience with the group, that would be great if they come on to the phone and do that.
And again, that's star then one.
Is there anybody on the line that's planning on filing a targeted review, or feel that they should, or question whether they should, that they want to share their scenario? It's a quiet bunch today.
And we are not seeing any further questions in chat or Q&A.
And I'm showing no questions in queue.
Any of the panelists have anything to share that's come up that might be useful to share? Candy, Reed, Lisa, Keisha?
Yeah, I think we hit on some of the high points, the scoring calculations being of concern and that process that we need to use, the targeted review, the fact that the new proposed rule is out, and we'll dive deeper into that, like you said, Mona, in the upcoming office hours, and we'll certainly have some webinars around that, I'm sure, and you'll be seeing some CMS webinars if you're plugged into those listservs, inviting you to listen in and hear some of the details about the proposed rule.
Mm-hmm. But in the meantime, you can reach out to any of us if you do have questions. The targeted review is something that each of the people with the EIDM accounts need to do as a practice. They need to log into the EIDM account. We're here for support, and we can give you some instructions on the EIDM account, but unfortunately we cannot file those targeted reviews for you. So that is something you'll have to do. If there are no further questions, we can close the meeting. I just want to check in chat to make sure there aren't any other questions.
And Mona, I just posted a link to the proposed rule fact sheet, the 28-pager that I was referring to, so people click on that.
Thank you. Perfect. Just as a reminder, our next office hours is scheduled for August 9th, 2018. Sounds like we may be doing a little bit of information about the proposed rule at that time. And then the one following that is September 13th. And the times are the same, noon Central and 1 o'clock Eastern Time, for those of you who want to join, and we'll be sending out invites to those. Just one last call for any questions that people may have. All right. With that, I'll thank everyone for joining us today. And as I mentioned at the outset of this call, we'll be compiling the questions that we had today, and the answers will be emailed to each of the participants of today's call. So thanks again for joining us today. We ask that you please take a moment to complete the brief evaluation that will appear when you close out of the webinar. Your feedback is much appreciated and is used to inform our future educational offerings and resource development. Today you will be automatically redirected to the evaluation. We ask that you please take a moment to complete the brief survey. So thank you very much, and stay in contact with any of your other questions. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.